Hi everyone, welcome to researchmd.com. Thank you so much for watching us. We got a great presentation. Our goal is to make sure we want to teach you everything, the most important fact, under 9 minutes. So repetition is the key of a subject. If you watch like 1 or 2, 3, 4 times, rather than watching like an hour-long video, you can, by repeating yourself, the knowledge is going to stay in your brain. So that's why all our presentation is going to be under 9 minutes with the key points for everything you need to know, okay? Thank you so much again. Again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency. I also teach medical students and residents. So let's get into our important topic and a painful topic today, trigeminal neuralgia, okay? Just thinking about the name, you kind of feel like how painful this whoever got this problem is. So what is it's a brief recurrent episode, severe sharp pain, unilateral pain in the distribution of one or more branches of the trigeminal nerve. That's why I call it trigeminal neuralgia, okay? And episodes are like abrupt in onset and abruptly can terminate, but very, very painful. It's also called a tic doulourax or trigeminal neuropathy. Epidemiology, peak incidence between age 50 to 60 years, more common in females. 150,000 people are diagnosed with trigeminal neuralgia every year. And what are the causes? Okay, usually caused by atrophy or displacement of the trigeminal nerve due to neurovascular compression, typically by artery in the cerebellopontine system. And cause of secondary trigeminal neuralgia can include multiple sclerosis, plaque in pons or trigeminal root entry zone, tumors such as epidermoid meningioma, AV malformation, aneurysm, skull-based bone deformity, connective tissue diseases, dual arteriovenous fistula, and genetic cause of neuropathy. So many causes could be this thing. So International Headache Society of Classification they classify trigeminal neuralgia. Let's look at their classification. There's 3 types: congenital trigeminal neuralgia, okay? Then you have secondary trigeminal neuralgia, and then you have like idiopathic trigeminal neuralgia. So let's look at each one. So again, 3 divisions. First one, classical trigeminal neuralgia, appears in second or third divisions, and also classical trigeminal neuralgia is purely paroxysmal. Patients pain-free between attacks in affected trigeminal distribution, and the classic trigeminal neuralgia with the concomitant or continuous pain is possible, okay? Now, when you look at the secondary trigeminal neuralgia, it may be called symptomatic trigeminal neuralgia, caused by underlying diseases known to be able to cause neuralgia. Patients often exhibit sensory changes on the clinical examination. That's also very common, sensory changes in the secondary trigeminal neuralgia. When you have idiopathic trigeminal neuralgia with no identified, it's idiopathic, you don't know what causing it, okay? And then findings may include contact between blood vessel and trigeminal nerve and nerve root, but without any evidence of morphological changes. So it's again, first one is a classic trigeminal neuralgia, then is secondary trigeminal neuralgia, and idiopathic trigeminal neuralgia. Okay, now if you look at the pathogenesis, we've got a nice diagram over here. It's usually caused by the vascular compression of the trigeminal nerve, the nerve root entry zone. Remember that. And then compression hypothesized to result in central demyelination of the nerve root entry zone, subsequent hyperexcitability, impairment of the nociceptor system. That probably causing the shooting pain. Demyelination may reach a level that allows ions to move in and out of the axon, resulting in the inability to immediately reestablish the resting potential. Axons tend towards stereodepolarizing, make them hyperexcitable. Hyperactivity of the primary efferents may induce central sensitization of the wide dynamic range of neuron in the spinal trigeminal nucleus. Crosstalk between nearby healthy nerve fibers may contribute to, again, hyperexcitability. Patient with more background pain appears to have loss of central inhibition of the nociceptive system. Okay, there's a lot of hyperexcitability in this. So if you look at the pain distribution, we got this nice diagram. V1, V2, V3, and V2 plus V3. Those are the three distribution you can see. The V1 is the ophthalmic branch. That's like 6% of the people. You can see that. V2 is the maxillary branch, 39% of the people. And V3 is the mandibular branch in 55%. Then you got V2 plus V3 combination is kind of noted in 9% of the people. Now let's look at the signs and symptoms. Electric shock, like severe pain. Okay, number of episodes per can range up to 70. Typically lasts from a fraction of a second to like 2 minutes, but very stabbing electrical shock pain. So if you have to remember, pain most frequently reported, we talk about the distribution of the maxillary mandibular division of the trigeminal nerve. Periods of remission like unpredictable. Nobody knows when it's going to come. Sometimes this huge break between lasts from week to years. And the right side pain appears to be more frequent. Okay, so electric like shooting pain, brief and episodic. So what kind of things can trigger this? Anytime there's a light touch to face, eating or chewing, cold winds, vibration, talking, shaving, brushing teeth, and smiling, all this can trigger the attack. Okay, diagnosis mainly based on the history and the physical exam finding, but again, you have to rule out the other causes, maybe to do an MRI to the alternative, some secondary cause of trigeminal neuralgia, example like tumors and all that. Okay. So IHH and IASP diagnostic criteria is given below. Diagnostic criteria for trigeminal neuralgia: recurrent paroxysm or paroxysms of unilateral facial pain greater than one division of trigeminal nerve without radiation beyond the trigeminal nerve divisions, and the pain characteristic paroxysm lasting anywhere from fraction of a second to 2 minutes, severe intensity, electric shock like stabbing, shooting, or sharp paroxysm triggered by innocuous stimuli within affected trigeminal nerve division, and the pain not better explained by an alternative diagnosis. Okay, mainly the physical examination and the clinical findings. So how do you treat it? The treatments are carbamazepine and oxcarbazepine. Those are the two main treatments, the first line treatments available. Okay, if carbamazepine and oxcarbazepine ineffective or lost efficacy over time, additional drugs you can consider lamotrigine and gabapentin. And alternative options, medical management, it could be maybe injecting with the botulinum toxin A, or add-on therapy for medium-term long management is also an option. Thank you so much for watching. A great topic, trigeminal neuralgia. Please support our channel by subscribing our channel. Thank you. Bye.